I am here. Okay.
Few more minutes. Let's people to come back. Turn on your camera, and we'll continue our journey. Everybody, if you're around computer, come back, turn your camera on. Don't worry about munching. I will screen share so nobody will see your faces. They will be so small. Okay, few more people, come back, come back. We're starting. Okay, everybody, lunch break is over. Let's go back to pieces. So to remind you where we are, we completed question number 1. That would include prioritizing concerns and to see when change took place. Question number 2, we've done risk assessment and we started to work on contributing factors. We have completed first part of contributing factors. Those are physical, that would include 5 Ds. And now we are moving to the letter E in the acronym pieces. E stands for intellectual. If you'd like to see where the intellectual is in your book, it will be on pages 25 and 28. Pages 25 and 28, they are on your screen. So as we mentioned before, all 6 factors are connecting to each other, and all 6 factors are equally important in identifying triggers for responsive behaviors. And before we are in order to begin our conversation on intellectual health and cognitive process, it's valuable to briefly review the healthy brain. So we finished at 40 minutes. So you can see on your screen, there is a schematic presentation of brain and its key functions. So somebody was kicked out. And in order to, and we need to review this, we need to understand development and the key function of the healthy brain, because it will help you to appreciate how a person who has damage in their brain interprets and interacts with world around them. And also to ensure that planning builds on the person's remaining abilities and does not focus on their cognitive losses. It's also helpful to see that brain evolved vertically into 3 levels. Let's start from the bottom. Instinctual brain is located at the bottom of the brain. It's this brain stem and back of the brain. That's this base of the brain controls breathing, blood pressure, balance, coordination, and fight and flight response. The next one is emotional brain. It's midbrain. Mediates both memory and emotions. And just to remind you that every memory from the past is stored in the brain with emotion. So every image, every experience has emotional context to that. And the last one to evolve is a thinking brain. Thinking brain consists of cortex and is responsible for higher and complex functions. And it's usually divided into 4 lobes, and they are colored differently on the schematic brain. The brain fully get developed to the mid of 20th. And just to review which the functions of each brain. So the back of the brain, the blue one, is occipital lobe and responsible for vision. Next one is temporal lobe. It's on the side of the brain, colored in green, represent language and language comprehension. So talking and understanding. Also memory and hearing, since it's closer to ears. Then parietal lobe, which is sort of like a pinkish. On the picture is responsible for spatial and visual perception, manipulating objects, and body awareness. And the last one is a frontal lobe, yellow on the picture, and it's responsible for executive functions. Thinking, planning, motor speech, organizing, problem solving, emotional and behavioral control, and personality. So please remember main function of the frontal lobe, because it will help us in the near future to understand behaviors. Understanding key functions of the brain helps us also to avoid assumptions. Some of the areas of the brain can be impaired with preservation of function in other areas. For example, person's speech is relatively unaffected with in the frontal lobe. However, the comprehension, which is stored in temporal lobe, may be impaired, and then we'll see that person cannot follow verbal instructions. And sometimes for us, it's difficult to imagine, because we see person is talking, but they're not able to understand what we're talking about. Or another example, person's memory and language stored in temporal lobe may be relatively well preserved, but their emotional and impulse control could be impaired, which is stored in the frontal lobe. And now sometimes we may assume that person is doing this on purpose. How often would you hear from your colleagues that residents are doing it on purpose? They know what they are doing. Though, unfortunately, in many cases, it may not be true. Let's talk a little bit about how brain responds and what part of brains would respond in a certain situation. Imagine that you are sitting in a parking garage or parking lot, walking towards your car, and it's late on a winter night. So you know it's dark outside, it's late, snow is falling just like now, and nobody is around you. You're expecting to be alone. Garage is dark, and there are only a couple of cars there on your level. And then suddenly you hear the sound of echoing footsteps behind you. And as you walk towards your car, steps get louder and louder. You quickly turn around, but you see no one around. But footsteps get louder and louder. And when you turn back again, oh my God, you see tall hooded figure walking towards you. What happens to you in that moment? How would you feel if you turn back and see a tall figure coming to you real fast?
Scared, right?
Yes, of course, you get scared.
Threatening.
Probably panicked too. What else would go through your mind and through your body?
I become defensive.
You will become defensive. How about your heart rate? How about your breathing? Everything will be on the alert. But actually, if you stop for a moment and think, do you have any immediate evidence that something harmful can happen to you? Any immediate evidence? Probably no, because person is far away. Not only they are far away, you don't even know who that person is. Probably that's your colleague running behind you and telling you, "Oh my God, you forgot your car key on your desk." You have no evidence that something harmful may happen to you, but you are already in a flight mode, right? So this parking lot experience is an excellent example how how your body responds to respond to stress, and what's the difference between emotional and thinking brain. So if we are if our emotions run sky high, we're not able to logically think what is going on around. Right? You can also transform and try to apply this situation to a person with dementia. They don't have capacity to think about, is there any evidence that something bad is going to happen with me? They don't have this ability to evaluate the situation. And they quickly go to the instinctual or emotional brain taking over their behavior, which means lots of time our clients with responsive behaviors, our clients with cognitive decline may rely on emotional or instinctual part of the brain, which means they will feel as the same person in that parking lot. So emotions are stored in amygdala and hippocampus. So which gives us an idea that person may not be able to think logically about everything. So we need to also consider then when you are in that moment, you probably lots of memories of difficult situation may come back to you, and all these memories are coming with emotions attached. So especially if person experienced stressful situation before, and that stressful situation would be associated with somebody reaching behind them or walking behind them, then their emotions come up and they may not behave in a logical way. So also we need to be also aware about our action and our responses when we are dealing with the person with responsive behaviors. So what is important in terms of intellectual assessment of client with dementia? For example, neurocognitive disorders such as dementias, acquired brain injury, stroke, and other neurological disorder could lead to some impairment, and this impairment could include anosognosia, impaired insight. So person doesn't know that they don't know something, and that's challenging condition, and that's also challenge for us to help that person, which can lead to the person having their own reality, which may not reflect the real situation around them. And we may consider person being stubborn or being in denial, though for them is real. This is why we ask you a few times, what would Maria think about your assessment? Because she could have different reality. and we have different. And also people will be acting on what is real for them. And we may see that, no, they're not acting in their best interest. But again, for them, it's real and they are doing the best they can. Also, they be less inhibited without any concern for possible risks. So remember Harry, he disassembled his lamp, but he didn't see it as a safety concern. He didn't consider those actions as risky actions. But for us, it's potential risk because it could be electrical damage and electrical fire. So that will bring us to the important key messages when we are communicating with person with dementia and cognitive decline. Communication with them is quite complex and include both expression and comprehension. Person, as we mentioned before, person with dementia and responsive behavior, they may be able to express themselves, but they may not be able to understand what we are talking about and why we need to do certain tasks and actions with them. Expression and comprehensions are functions originating in different parts of the brain. This is why we are dividing aphasia into two parts, expressive aphasia and receptive aphasia. So expressive aphasia means person cannot express themselves, and receptive aphasia means person cannot understand what other people are talking about. In this situation, nonverbal communication becomes very, very important. So the way we convey our messages without using words is very important. Our body language, smile, facial expression, tone of voice, all of it becomes very important for the person with cognitive decline, because these signs that they would rely on in order to understand the situation around them. Again, if you are talking to a person with dementia and cognitive decline, please remember to avoid assumptions and assuming that because person can express themselves, they can understand what I'm saying. Not always. That is bringing us to ACE of dementia. All those ACE of dementia are described in your manual on the pages 61 and 66. And just for you to get a little bit more familiar with your book, so when the session is over, you won't get lost. So probably during GPA, you've heard about 8 ACE of dementia. What we're missing here is attention deficit disorder. But let's focus on those 7 that are more important. We will not go over each of them individually. It's not the purpose of this course, but let's just quickly review them. Anosognosia is loss of insight and knowledge into their own disease. So person does not understand that they do have some deficit. Amnesia, it's loss of memory. Aphasia, we just talked about it a little bit, it's loss of language, both expressing and understanding, written and spoken language. Agnosia, loss of ability to recognize object, faces, shapes. Apraxia is difficulties with performing voluntary purposeful movements, something that they want to do, but they cannot. Altered perception, that's very important, and altered perception is different from hallucinations. It's visual perception, depth perception, misidentification of objects. And apathy, it's loss of motivation and interest. Not sometimes so much interest, such as ability to start a new movement. So that's also apathy. So knowing all of these 7 A's, and you can see them in your printout, because in the printout you have all the slides. If you can keep it in front of you, I give you a moment to locate that slide. I suggest we'll start working on Maria. Let's get back to our friend, and I'll share with you a here. So again, just to show you where we are, I didn't fill out the risk assessment that you've done, and now we are filling up, continue to fill up pieces template. So we've done the physical, and now we're moving on intellectual, neurocognitive changes. So, and the last column is flagging priority action for question number 3. So let's go through all 7 A's and see if Maria is suffering from any of those. And our role is not only find what is Maria suffering from, but also see which one is directly contributing to responsive behaviors. Because if you try to put in everything that Maria is suffering or hypothetically could suffer from, think about if you flag something, you need to do something about it in question 3. So let's focus only on those conditions that directly explain or contribute our priority concerns. And I remind you priority concerns that we fill up with you right here. Physically and verbally responsive behaviors, raising fisted staff, screaming and insulting staff, want to go home and neglecting her activity of daily living, hygiene and eating as well. So these 3 priority concerns we identified for Maria. And now let's see which one of those A's explain or contribute to those priority concerns. Let's start with amnesia. What do you think? Is the amnesia contributes to any of the priority concerns?
It could be contributing to the neglecting of her ADLs. She might just be forgetting to go down for her meals, or forgetting that she didn't shower today or yesterday. She might have thought I showered yesterday when she actually didn't.
Yes, thank you. May not remember that she needs let's say care. Let's use our jargon, care, care and eat. Okay. Anything else?
Apathy, apraxia.
Let's hold on the apraxia when we go. Let's go down term by term. Is there anything from amnesia part that could contribute or explain responsive behaviors? I give you a little trick.
Dementia symptom that can include memory loss?
Yes, she suffers from memory loss, but how amnesia or a memory loss contributes to her priority concerns?
could forget like where she kept her stuff.
Okay, you're on the right path. I would rather say she's forgetting where she is living right now, right?
Yeah.
Yes.
That's because she says, I want to go home, but now that's her home.
It could be a safety issue.
Yes.
Could you
She
please
forgets
clarify
her
safety?
walker.
Okay, okay, yes, she forgetting her walker.
Yeah, or
Zone
even
out.
if she were to, let's say, have the ability to leave the facility, it poses a safety issue that she could get lost if she leaves the facility trying to find home.
Forgetting her walker. Okay. So, next one, anosognosia. Is there anything is there any priority concerns that anosognosia can explain?
Refuses assistance from staff. Like she's not aware that she needs help. She thinks she's fine the way she is.
Thank you. Excellent. What she tells them, I don't need your help. I don't need your help. And she also she doesn't understand that she cannot live alone, and she tried to leave. Trying to leave. Also, what do you think? Would anosognosia contribute to her being frustrated or upset at stuff? In some way, yes.
She might think like, why are they bothering me? I'm perfectly fine.
Absolutely, yes. Yes, she is. Next, move to the next on the list is aphasia. Is there anything from aphasia part could explain her our priority concerns? She appears to be able to actually communicate clearly. We know that. We heard her. However, the question is, do you think she can understand same clear our instruction and our reasoning?
No, she does not.
No.
So
We
maybe
don't.
receptive aphasia?
What are the evidence for receptive aphasia?
Like maybe when the staff invites her to come for meals, she doesn't understand what they're saying,
Could be,
unless
absolutely.
it's non-verbal communication, like to show her.
Absolutely. We don't know yet
Or
how
for
clearly
care.
she can understand. So receptive aphasia, I would put question mark because we need to clarify how much she can understand. Can she understand one-step instruction, or we can go further and provide her with 2 or 3 steps instructions? We don't know, but we suspect. So that's the question mark. We need to investigate a bit more. How about agnosia? Do we have any evidence that agnosia may play part in her behaviors of concern?
She forgetting to take walker, so she maybe is not or recognize for what is supposed to use be.
Could be, but Walker probably is also anosognosia or amnesia a little bit. Probably Walker can be explained by anosognosia and amnesia. So there is no clear evidence yet. How about apraxia? Can she dress up herself? Can she do some easy activities of daily living?
Neglect her hygiene, so can be.
But can she change her clothes?
No, she was wearing the same clothes for a long time. So it starts.
Here is two different things. One is her ability to take off clothes and put the new one. She's able to. Remember, she's in a retirement home. She's independent.
She's
Another part
able-
of it,
Yeah, she's
does she
able to put on-
remember about it? Does she see a need in changing her clothes?
No, she doesn't see.
Yeah.
She's in
Yes.
to change the clothes.
So if she is able to undress and dress herself up, there is apraxia, then apraxia doesn't contribute to responsive behaviors. But if she's forgetting or insisting that, oh, I don't need to, so then it's probably anosognosia. Sometimes, again, there is no right and wrong. Even if you identify apraxia here, it's fine too, but then you need to work on what's the driving force for certain behaviors. So again, apraxia is about not being able to brush hair or or brush your teeth or put clothes on. Maria can't do that because we don't have anywhere evidence that PSW comes to dress her up. Maria, please go ahead.
Apraxia also refers to the sequencing. So for example, if Maria was coming out with her bra on top of her shirt, that means she got the order wrong. You know, that might be that she has apraxia because she's messing up the order of it. So she physically can do it, but the sequencing of the task is wrong. Or like people who they know they have to brush their teeth, but they brush and then they put the toothpaste on at the end. They've mixed up the order.
putting on the face.
Yeah.
So for now, we don't have enough evidence that apraxia is actually present in Maria. How about apathy? Apathy is inability to initiate new action. For example, person is sitting down, they are physically capable of standing up, but they cannot switch between sitting and getting up. So somebody else needs to get them out of chair. Is it applicable to Maria?
No.
No, not yet. So altered perception. Is she complaining about seeing someone in her room, seeing something that is not there? There is no complaint, there is no evidence, and that's absolutely fine if some of the subcategories of every domain is not present. It's okay. You don't have to drag in everything. So right now we know that amnesia, agnosia, and aphasia can actually contribute and explain priority concern. And we put a check mark over here because we know that later on we need to do some actions around it. Okay, so I let it settle for a second, and while it's settling with you, I switch slides. Do you have any questions so far how we end up doing that? Very good. So P, physical, is done. E, intellectual, you already identify things. I have one more slide to share with you. It's about tools that could be applicable for slide. So here are tools that you could use in your settings. Those are divided into two categories. On the dark blue screen, you see very brief cognitive screening tools that are under 10 minutes. Why do you think we're doing here cognitive screening? Because we need to know what she's able to do And is she able to follow instructions, how her memory is, how her short-term memory is, what she can understand, and things like that. So for example, standard mini Coke, 3 words recall and drawing clock. It's really, really quick. Also, just a clock drawing test that also gives you some idea also about her visual spatial spots and other things. Animal naming test checks verbal fluency. You ask person to name any animals in 60 seconds and you count how many. There is also MMSE2 is a brief version of standard MMSE and it will check registration, orientation, and recall. There are also some cognitive screening tools that would take you a bit longer, and those cognitive screening tools are MoCA, Montreal Cognitive Assessment. That's typically done for the beginning of dementia, light to moderate dementia stage. Then there is a standard mini mental exam that it will be good for a moderate to more difficult stage of dementia. Let me admit someone. And there is another also standard mini mental state exam, which you can compare scores to standard MMSE. So all these screening tools you can find in your manual on the page 121 to 128. You can see the I indicated it on a slide. Oh, sorry, on a slide over here, 121, 128. So what's important to remember about intellectual part is that sometimes you may not know everything about the person, and that's okay to leave it with the question mark, as you need to know more about the person. You need to do more assessment tests to evaluate are your assumptions right or not. So please do not assume that something is happening with your client. The same way, like we were assuming that what if there is apraxia there? It's good to assume it, but you need to base your assessment on evidence. Do you have any question about intellectual part of it, intellectual domain of contributing factors? Okay, we can go to the next one, which is first E, emotional.
Can I just add one thing? So for Maria, because we weren't too sure, like, is it apraxia, is it amnesia? So then our action would be to actually give her a cognitive test. So for example, if we did the MMSE, then it would show us, depending on which question she got right, which A it is. So in the MMSE, there's a question that says, take this paper, put it in your left hand, fold it in half, and put it on the floor. Okay, that would tell you if her brain can sequence her actions. Apraxia. In the MMSE, there's a question where I'm going to say 3 words and I want you to repeat them back to me. House, tree, car. Then you talk to her about something and then you go, what were those 3 words? And if she has no memory, then you know, oh, that's amnesia. Okay, so it's important, like if we get a score, sometimes we say, oh, her MMSE is 15 out of 30. Okay, but that doesn't actually tell us anything except that she has moderate dementia. Which questions did she lose marks on? That will tell you which A she has. So I know sometimes we get that in the report, oh, it's 20 out of 30. Okay, but where's the questions? I want to see the actual paper to see which A it actually is. Okay, and sometimes if you're not the one doing the MMSE, you'll have to like ask the social worker or the OT, like, which ones did she get wrong? Okay, thanks. So moving on to E, which is emotional. And I hope the the person who had thoughts about depression remembers what those thoughts were, because I asked you to hold on to it till after lunch. So we're going to talk about emotional factors. Pieces has decided they're going to focus on depression as one of the main emotional factor for the population that we work with. Just because we're focusing on that doesn't mean there aren't others. So emotional factors can be as simple as, I got into a fight with my roommate, so now I'm really angry. And that's an emotional factor. I'm angry today and I'm yelling at everybody. Other emotional factors could be anxiety. So there's a lot of, it could be grief, lots of other things. But for now, we'll focus on depression as the main emotional factor. Okay, can everyone see the slide okay? Yes? Okay. So I'm going to show you this video. Let me just make sure the sound is on. And it's called, Why Isn't Dad Fishing Anymore? And while you're watching this video about depression, I want you to listen to kind of the language they use to describe it and see if you notice any stigma in the language they use, because it's a bit of an older one, but it's still really relevant for today.
When she first mentioned depression, I said, no, that's just women and sissies. That's what I told her.
When I actually felt really, really sorry for him is I came in here one day and he was sitting in a chair and he looked so lost and so alone. And that hit me really hard. Like I felt like I had actually lost my father.
Symptoms of depression, sadness, lack of interest, withdrawal from things that you normally enjoyed are not a normal part of aging. It is a medical condition that needs to be addressed and hopefully treated.
Here, I've driven the school bus for 27 years, and I've always lived for trout fishing. I love trout fishing. I do a lot of welding, just on my own, Yeah, I enjoyed the things that I did, really. When I retired from the school bus, and you had to retire when you were 65 from a school bus, and the first thing that hit me, hey, I'm too damn old to drive a school bus. Now that's going some.
This gentleman was very familiar with the area and now was starting to get lost in places that were very familiar to him. As we get older, a lot of times when we're forgetting things, we may worry about them a little more because of the risk of dementia, Alzheimer's disease being the most common.
Well, I thought he was depressed, but I didn't think that was the issue. I thought, okay, he's depressed, but he has Alzheimer's.
It was a gradual thing. I didn't wake up one morning and say, whoa, this is, whatever. No, it was gradual and probably strung out over a fair amount of time, too. Right after I get done on the school bus, 2 weeks after. And I had that prostate cancer. That took the wind out of my sails, pretty much. Yeah, and then I had a stent put in my heart. And we lost our grandson. He was caught under a car, killed him.
In Dan's case, although we can't say for certain that any of these one things or the combination of them all caused his depression, but they certainly may have played a role. Depression for the first time in seniors oftentimes doesn't present the same way as it would in a younger person. In many cases, such as Dan's, he was having trouble doing things that he often did. And these are some of the things that we look for when screening somebody for depression.
I had this depression that took fishing, hunting, and everything else, it seemed, that I had any interest in before. It just ruined it,
As far as his interests, like his character, what he was interested in, that just died. Yeah. Yeah. So he became a negative being, which was really sad. It's like he was in a shell, like a cocoon, all by himself. I would come back here, Mom and I talked for hours about his behavior and the way he was, and thinking, well, just take him to the doctor. See, you need family members, you need people who care, who love you.
And, you know, the fact that you came and you sought help
Yeah.
was the most important thing you could do, and including your family, because they're also your supports. You didn't go through this by yourself.
Oh, no, no, no.
Even though you were the one that was suffering with it.
Yeah.
But you also had people that were able to help you.
We were all relieved that it was depression and he could actually get help for it.
I'm not as negative.
As you were.
Nowhere near. A big difference that I can see myself. Once we got the help for me, well, yeah, I was right back into things. It all came back after I seen Diane and got the proper medication for it. Well, it all came right back. So there is help there for depression, that is for sure.
Very quickly he saw a difference, and his family noticed a difference. He was doing things that he normally enjoyed. He was back to looking forward to fishing again. Couldn't wait for hunting season. Was back welding and just being busy, interested in life again.
Well, there is cure and there is hope, and don't give up, and stick together as a family, and you'll get through it.
Look at me, I'm not depressed now. Nobody enjoys life any more than I do.
My dad's back.
Stop sharing for a second so you can see everyone. What were your thoughts about the video, and did anyone catch any of the stigma associated with depression?
Yeah, depression is not related to age.
Sorry, I can't hear you. Say again.
It's like the depression is not related to age.
Oh, yeah. So just because you're older does not mean that you'll automatically get depression. It's not related to how old you are. Did you catch his first sentence right in the beginning? He said, when someone said depression, I thought, no. Yes, he said, depression is for women and sissies.
Yeah.
Right? So not for men. That's what he thought. Right. And that kind of, the stigma of mental health is not as bad as it used to be. But when you look at the population we're working with, they grew up in a time where we don't talk about mental health. So depression is one of those things that not a lot of the people we work with will admit to or feel comfortable talking about, or their families will feel comfortable talking about. Just a quick story. I used to work at CAMH. And does anyone know CAMH's address? Those of you in Toronto, what's the address for CAMH? Oh, quiz. It's 1001 Queen Street. It used to be 999 Queen Street, but there was such a huge stigma that if you were crazy, you would end up at 999 Queen. And parents would threaten their kids, like, if you're bad, I'll send you to 999 Queen in Toronto. And that's where all the crazies are. Crazies. So the stigma became so bad that going to 99 Queen was so bad that CAMH changed its address, and it's now 1001. So it's mental health is really stigmatized. And so especially for Dan, he's a guy, He's not a sissy, so how could he be depressed? It's kind of that attitude. And then you have the cultural aspect of it too. So certain cultures, for example, I'm Filipino. In the Philippines, they pay for healthcare and nobody wastes money on mental health care because you're too busy. Like I'm bleeding and a social worker. What's a social worker? So that's where my parents grew up, and that's the mentality they have here. So I also supported a Ukrainian nursing home. Over there was a lot of trouble trying to get people on antidepressants because it was heavily stigmatized in the culture. Nobody wanted mom to be on antidepressants. So there's lots of layers in treating mental health illness. So we have to be mindful of that when we identify depression as a possible cause for behaviors. So some people think of it as a sign of weakness. Some people think mental health is not real. So there's a lot of obstacles there. That being said, we have to go to concrete assessment tools, okay? So there's a couple of tools here. Let me just go back. Oop. Okay, so Ziggy CAPS is an acronym where it doesn't actually, Ziggy CAPS is not really a word, but those are the first letters in sleep, interest, guilt, energy, concentration, appetite, and psychomotor, and suicide. So 5 of these letters have to be present over a 2-week period to indicate depression. So you could say, I screened Maria using Ziggy CAPS. She has these 5 signs of depression. It could be S for sleep disturbance, too much or too little. Could be interest, loss of interest. She used to go to church, now she doesn't want to go to church. Could be guilt. Oh, I'm such a burden to my family. I cost them so much money. I've done terrible things. It could be energy. They have no energy at all. I just want to stay in bed all day. Could be concentration. If someone is depressed, they might score lower on an MMSE because they're depressed. So we might think it's dementia, but really it's their depression. So that can cause a false score on a cognitive test or a clock drawing. They might lose motivation halfway through the clock drawing and say, that's good enough. But once their depression is treated, their clock drawing is actually correct. Appetite. Some people eat more, some people eat less. So any kind of weight loss over 5 kg in a month is a sign of depression, weight loss or gain. Psychomotor, they're either very, very slow or very, very agitated. And then suicidal thoughts or ideation or attempts. Okay, so you have to ask if someone says to you, I thought of jumping off my balcony. Okay, you have to take that seriously. You have to say, do you have a plan to do that? When are you going to do that? Do you have a safety plan? Those kind of things. And then you have to ask, well, do you actually want to die? And most people will say, no, I don't. I've just thought about it, but I could never do that because X reason. Okay, so you do have to ask. Talking about suicide does not suggest suicide, so you're not going to make the person more suicidal by talking about it, but we do have to talk about it to assess the intent and the access to the means of doing it. For example, if they live in a locked unit in long-term care, there is no balcony, we have to assess that, okay, that's safe right now, they can't actually do it. If they live in a condo building on the 20th floor, there is a balcony, they have access, okay? So in older adults, it's a bit of, those are Ziggy CAPS, those are the textbook definition, but in older adults, they also have some atypical changes. Because they are so complex, they also have that stigma. They might not just come out and say to you, I feel depressed. They might complain more about physical pain because, again, that's more socially acceptable. So they might say, I just feel so weak all over, or I just have pain everywhere. Or they might say, oh, I can't breathe sometimes. I think I'm having a heart attack, but it's actually anxiety and a panic attack. Okay. They become irritable. We get a lot of referrals for what people refer to as, well, I think he's just a jerk. Like he's yelling, he's swearing, he's fighting the staff. He must have just really been a jerk all his life. But really, it is a gentleman who is depressed, because in men, depression shows up more like anger and irritability. In women, depression shows up with more sadness, withdrawn, more the typical picture that we think. But a lot of the time, the referrals for angry outbursts, yelling, throwing things, a lot of the times it's a man with depression because they're showing it as more irritable symptoms. And so many times staff have said, you know what, maybe that's just his personality. Maybe he was abusive and just a grumpy, terrible guy. But it's actually he's depressed. Okay. And then some older adults will self-treat, and they will use alcohol or other substance as coping. Okay. Here are some risk factors for depression. This is another big thing, like pain and long-term care. Pain and long-term care is 80% of people who live in long-term care have chronic pain. And depression, the statistic, I don't have it offhand, but it's also underdiagnosed. A lot of people in long-term care have depression, and it just goes undiagnosed again because of the stigma. Well, of course they're sad. Their husband died. Well, of course they don't want to do anything. They're sick, they can't walk, right? And you know, it is stigmatized, but these are the risk factors, and everybody needs to be mindful of these risk factors. Because depression, unlike dementia, there is a cure, right? So it even gets harder to diagnose when the person has dementia already and then depression on top. That makes it extra tricky. But it's still possible. So 90% of people who start antidepressants, that will fix their depression, and they can go back, like Dan, to living the life they used to live. Okay, so we have to find it, screen for it, and treat it, which is really tricky. So if we look at this list, which ones apply to Maria? What risk factors does she have? Anybody?
So, she's refusing to eat. She's neglecting personal care.
Female.
Yep.
Then relocation, because she moved from one area to another. And then widow or divorce could be like if husband is not there, but recently she remembered him, so she's currently grieving. So that could be there.
Perfect. Yeah,
And
she's female. She's lost her
medication too.
husband.
Yeah.
She's taking lots of medication. She's asking for sherry. She's refusing to eat. Yep. She is
Her lifelong coping. Oh, sorry.
Yeah, go ahead.
Her lifelong coping pattern of using alcohol.
Yep. Yep.
It's nice.
So she's got quite a few risk factors, so we should be flagging it for her. How many people think depression could be a contributing factor for her behaviors? Okay. Yeah. So I'm not going to pull up the document because all we're going to do is say depression, check. So we don't need to do that, but we're going to flag it for action. And how are we going to assess or screen whether or not Maria has depression? What tools are you guys using? Anybody using any tools? No? Okay. Here are some suggested tools. For people with no impairment or mild cognitive impairment, we could use the geriatric depression scale. That is just an interview questions where we ask people, do you feel hopeless? You know, do you feel XYZ? That needs some insight into their feelings. If you feel like the person cannot answer that properly, then you have to switch to another scale. We talked about Ziggy CAPS. They have to have 5 of those letters over the last 2 weeks. There's also the BASDEC and the PHQ-9. The PHQ-9 is for people under 65. Okay, so if they're 50, 40, whatever. Most likely with the population that we work with, we're using the Cornell scale. The Cornell scale is really quick because it's not the person self-reporting. It's the staff or the wife or the daughter. And it's just a little 1-pager of questions. And you ask, have you observed these in the last 2 weeks? Have you observed anxiousness, a worried face? Have you observed hand wringing, hair pulling, those kind of things, sleep disturbances? And then you rate them, either moderate or severe or absent. And then based on that, you add up a score. In all of these screenings, so the GDS, the Cornell, they have a score at the end. So for the Cornell, a greater than 18 score indicates they are depressed. Greater than 10 is possible, and there's similar scoring to the GDS. So then you just screen and flag it to the doctor. As it depends on your role. These are validated tools, but anyone can do them. But your organization might have different roles. So for example, sometimes the BSO lead does the Cornell, sometimes it's a social worker, sometimes it's the nurse. It's whoever in your organization can or wants to. Okay. This is all in chapter 5, if you want to take a look for yourself. Chapter 5, page 129. Yeah. So which one do you think we would use for Maria? Which one would you like to use? It's up to you. It's your Maria.
Cornell.
Okay, yeah. So Cornell, because maybe we've identified that she's already got some amnesia, some anosognosia, her insight might be poor, so we're good with the Cornell. We're going to ask the PSW, the nursing staff, and maybe her daughter to score the Cornell for us. Any other ones we could use? We could also use Ziggy CAPS. We can just, again, ask the staff who work with her, have you seen this, 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 and this? If she gets 5 or more from the last 2 weeks, then we can say, I think she's depressed, and let the doctor know. Okay, so Ziggy CAPS and Cornell. You could have started with a GDS, but you might soon find out that she doesn't have a lot of insights, and so that's okay. Sometimes we try to give people the benefit of the doubt and do that one first, but then they're not able to answer, so then we switch. Okay. We will talk a little bit more about this in day 2, but just a brief note that depression can also cause psychosis. So we think, oh, that's definitely dementia. This person's hallucinating. They believe that people are poisoning their food and they're going to kill them. That's dementia. And most of the time it is. But when depression is very severe and left untreated, it can also cause hallucinations and delusions, which are a form of psychosis. So psychosis, when we say that, it's like a break from reality, okay? It comes with delirium. You can also I can have a psychotic break when you're in a delirium. You start seeing things and scratching bugs on your arm. But it can also happen in depression. The thing that is something we have to look out for is usually the delusions in depression are mood congruent, meaning they're depressed delusions. So some people maybe with schizophrenia, they think, oh, I can fly. I can hear all these voices telling me how great I am and I'm going to be president and I'm the queen and I own this whole building. And it's very grandiose. But someone with depression, their delusions are sad. Nobody likes me. My spouse is cheating on me. My marriage is falling apart. All the staff gossip about me. Someone's coming to kill me. They're very low mood. So it matches the mood of the depression. Okay. So when you see anything new like this, or hallucinations, someone has a gun, someone's chasing me, they're very low mood. We can start thinking, is it depression-induced psychosis, not just dementia or a UTI? Does that make sense? You can also have low mood delusions in depression, in dementia, but they are more likely in depression. But again, it's not our job to diagnose. It's just something to be aware of. That's something to notice. And we'll talk more about this in day 2. Okay. So for Maria, we decided, yes, she could be at risk for having depression as a contributing factor. And we're going to screen her using the Cornell and the Ziggy caps. Any questions about depression as an emotional factor? Once you screen her and once you discover she has depression, then getting her started on antidepressants will be a whole other battle, right? How many people find it's easy for people to accept that they have to take antidepressants, or their POA to agree? I see some shaking head. You want to share? What does your shaking head mean?
There is always going to be lots of questions. They won't accept. No, that's not it. And what are the risk factors from taking the medication? So,
yeah. So mom's not depressed. She doesn't need pills to be happy. Those kind of things. We do have to kind of, part of it is educating the family or the decision maker or the person themselves. And I really like to do that by equating depression with diabetes. Okay, so I like to explain that, often a lot of people know about diabetes, right? So they know that the pancreas doesn't produce insulin, so we give fake insulin from outside, right? And most people say, yeah, they need the insulin because their body doesn't make enough insulin. That's why we give it to them. So I like to talk about depression as, your brain is not making enough serotonin. It's not making enough happiness in the person's brain. So we're giving them artificial, we're giving them medication to keep their serotonin levels high. Okay. So I don't even call them antidepressants because what they really are, they're called SSRIs, right? Selective serotonin reuptake inhibitor. So they stop the serotonin from getting reabsorbed. So if we make it more clinical, sometimes it helps explain that it's actually their brain's not producing enough, just like their pancreas isn't producing enough. And if they had diabetes, we would treat it. So if they have depression, it's a disease, it's an illness, we need to treat the chemicals in the person's brain. Sometimes that works. Sometimes it's about highlighting the benefits. Their memory might be affected by depression, their hallucination, their delusion, those can all go away. So imagine if mom's memory improved, if mom no longer had delusions because her depression is treated, right? And then the success rate, 90% of people with depression, they take the right antidepressant, they're okay. We also have to be mindful too. Sometimes people say, oh, it's been 3 weeks on this medication and it's not working. There's no point. Cancel it. We have to educate the family and the decision makers. It takes 1 to 2 weeks for symptoms that are physical to improve, like sleep and appetite. But for mood, like someone having irritability, suicidal thoughts, that can take 6 to 8 weeks to improve. So we have to provide a lot of education. Okay, hold on, be patient. If it doesn't work after 8 weeks, then we can talk. Okay? So depression is one of those really tricky things. that we really need to get on top of, because a lot of problems can be solved if it's treated. A lot of behaviors can go away. All right. Let me ask Irina. Do you want, or I'll ask you guys. Who needs an afternoon break at this point? Yeah. Okay. Let's take a 10.
Time actually.
Oh, we are good. Okay, let's take a 10-minute break. We'll come back at 2:20, okay? Thank you.